So older, in terms of unmet needs, we could very much benefit from research into the use, into determining which medication might be appropriate for an older individual based on their clinical profile. And the clinical profile can include things like comorbidities. So for example, is it more appropriate to use one drug versus another for sleep if the patient has a major depression versus gastroesophageal reflux versus sleep apnea? So a clinical profile for each drug that is more specific for the underlying comorbidities might be helpful. Number two, it would be interesting for us to be able to develop a rationale for using different receptor drugs in older individuals. So would a melatonin receptor agonist be more appropriate for this type of patient versus a GABA receptor agonist, for example? That would be very helpful. Number three, we really need more research on development of remission. So we know that these sleeping pills help groups of individuals, but how can we maximize the remission rate, that is the number of patients achieving a certain level of improvement, i.e. almost cure? How can we maximize that? Currently, the best we can do is about a third of individuals reaching that point. How can we improve on that? And finally, how can we ensure that we can minimize these side effects in older individuals? Cognitive decline, motor imbalance, falls, and so on. How can we ensure that there's a greater safety profile with these medications while at the same time helping them sleep would be a very important consideration. Yeah, there are a number of other drugs being developed for insomnia. They're either in the realm of orexin receptor antagonists. Some are being developed in the histamine system. The cannabinoid system is being explored for possible sleep initiation and maintenance. Interestingly, there are some non-drug strategies being developed, such as a head cooling device, helmet which is placed on the head at night, which may actually cool the head and potentially help sleep. Finally, there are a number of wearables being developed, wearable technology such as the technology which assesses and gives direct feedback to the patient in terms of the depth of their sleep, watches, wristwatches, and so on, gives the patient direct feedback in terms of depth and continuity of sleep, and then introduces various therapies such as music or sound, relaxation therapy. So those are being developed as well, which are an intriguing way to treat insomnia in a non-pharmacologic fashion. I think it's important to recognize that insomnia is very common in the elderly, and it's impactful. It has consequences. So number one, ask about insomnia. Ask the patient, how do you sleep? Number two, if the patient doesn't sleep well, enter into a systematic evaluation. What other comorbidities do they have? Ask about apnea, ask about restless legs, ask about pulmonary disturbances and so on, depression and so on and so forth. Identify those conditions, treat those conditions, and if insomnia does not improve, since it can have consequences, try to address insomnia first using behavioral techniques, cognitive behavioral therapy, lifestyle improvement, relaxation techniques, and improvement in terms of the way people live their lives. Secondly, if that's not effective, direct management is appropriate, but be careful about the drugs that you use. There are certain drugs which should not be utilized in insomniacs now. We know that they can be dangerous, and yet there are others that seem to be safe. So know your drugs and use them judiciously in the case of insomnia.